Good evening. Welcome to the American College of Radiology's Quality Payment Program Year 2 update. I'm Dr. Gregory Nicola. I'm the chair of the MACRA committee for the ACR. The MACRA committee has actually been around for 3 years, even though this is the second year of the Quality Payment Program. We were created immediately after the MACRA law was passed in 2015, so we're coming up on our 3-year anniversary. We were created under the leadership of Dr. Geraldine McGinty, the current Vice Chair of the Board of Chancellors, and Dr. Zeke Silva, our current Chair of the Economics Commission for the ACR. We were originally tasked with responding to rule language for the QPP from Medicare, but we were also tasked to educate the membership on what exactly the QPP meant for them and all the updates, and that's exactly what we're doing here tonight. I've brought 2 of our most illustrious experts from the MACRA committee, Dr. Richard Heller, a practicing radiologist in Chicago, and Dr. Lauren Golding, a practicing radiologist in Winston-Salem, North Carolina, to provide that update to you. A few housekeeping items before I turn it over to Rich and Lauren. One is this is going to be a recorded webinar. We will place the recording of it on our YouTube channel, the ACR YouTube channel, and then a link will be provided on the MACRA tab under the acr.org website and under the QCDR tab. So you'll have access to this several days after this is done. The recording will then be posted. We will have a question and answer session after, immediately following this, to use the entire hour. We expect the talk to be about 40-45 minutes. During the question and answer session, feel free to raise your hand inside the GoToWebinar website. And then you can type your message in the chat section for questions. You can do that anytime during the talk, but we probably won't get to them until the end. And that is about it for the housekeeping items. So at this point, I'm going to turn it over to Dr. Rich Heller, who's going to give you the first part of the QPP Year 2 update. Thank you, Rich. It's all yours.
Thank you, Greg. It's an honor to be joining you and Lauren here this evening. So without further ado, let's go ahead and jump in. So this will be the agenda for this evening. So I'll be sharing duties with my colleague, Dr. Golding. I'll be going over with you some available resources, then talking about general updates, things that are new for the QPP in Year 2, mostly about MIPS, and then we'll dive into the 4 performance categories of MIPS, focusing on what's new for this performance year. And then Dr. Golding will conclude with some issues on new participation options and some things on alternative payment models. So we have one take-home message for you. If you learn nothing else from the entire webinar, our big one take-home message is that there is absolutely no reason to get a penalty this year. This is another transition year. The government has made the performance threshold, the bar, relatively low, meaning that it's pretty easy to avoid getting a penalty. Some people are going to get a penalty. However, we would encourage all of you not to be one of those people, that it's pretty easy to avoid getting a penalty. Don't be one of them. So let's talk about resources that are available for you online, because there's a lot of them. The first one I'd like to highlight is the American College of Radiology website itself, acr.org. If you go to the Advocacy and Economics tab and you click on Legislative Issues, you'll see this MACRA and Related tab. Click on that. There's lots of useful information here. Now, Dr. Golding and I will not be going over a lot of the background of the legislation as well as a lot of the reasons it came to be. All of these things have been handled previously. I'm highlighting a prior talk by Dr. Nicola about 1.5 years ago. He went over a lot of the MACRA stuff that Dr. Golding and I are not going to be going into. We're really going to be focusing on what's new for this second performance year. The government has actually put out a lot of useful information. You can see on my screen here the URL for one of these fact sheets. You can certainly screenshot this, or actually it's very easy to Google. I've actually used this resource quite a bit. Some of my graphics actually come from this. It's pretty well written, and it's a very nice resource about what's different for Year 2, what you kind of need to know. Other than the ACR website, the website that I use the most is this one. It's qpp.cms.gov. It's pretty user-friendly. It's got good graphics and explains what you need to know. One of the most important options, I think, on this website is this NPI, this National Provider Information Number program. So as you can see right here, you put in your NPI number, and it will spit out lots of useful information that's relevant and specific to you. So I actually did that. So I know I practice with radiology partners, and I do my clinical work at the University of Chicago. So I'm showing this with their permission. So this is my real information. So as you see on the bottom left-hand side of the screen, As an individual, I'm exempt from MIPS. We'll talk about why that is. But as a group, I'm actually included in MIPS. If you look on the right-hand side of the screen, you'll see some more important information that would be relevant to me as an individual or as a practice. One of those things is my patient-facing status. As an individual, I am labeled as non-patient-facing, but as a practice, I am not non-patient-facing. I also do not qualify as a small or rural practice, either as an individual or as part of a group practice. And again, I got all this information by putting my NPI number into that website. Something else that's on the website that I wanted to highlight, one of the themes that the government has said is that they want to limit the burden, particularly to small and rural practices. So they've created a lot of resources for small and rural practices. If you want to read more about it, there's a whole bunch of information here on this website for you under the About tab. Click on Small, Underserved, and Rural Practices, and you'll read a lot more information about small and rural practices. Finally, there is actually a help desk you can call. Now, I know it works because I physically called it as recently as this morning. Just before I did the call, I wanted to make sure it actually still works. So I called it this morning. Now, I am not going to guarantee that it's an easy, smooth system. In my experience, it has not been, but it is there as an option for you. There's also an email you could use. If all else fails, you can email them your question. So let's talk about the legislation itself. Now, I'm not going to be going into a whole lot about it. That's been handled previously. Suffice it to say, MACRA did lots of things. It repealed that SGR or doc fix. It reauthorized the Children's Health Insurance Program. And important for us on our call today, it created the QPP, or the Quality Payment Program. And this is sort of rethinking the way that the government is paying physicians via Medicare. So the QPP has two arms. One of them is MIPS. That's that modified fee-for-service system. It's still fee-for-service, but the actual amount you get paid gets adjusted based on your performance. So it's a modified fee-for-service system. The other one is this advanced APMs, alternative payment models. Most of this talk is going to focus on MIPS because that's where a lot of radiology is right now. However, APMs are a very important part of the QPP, and Dr. Golding will be addressing this. So as a very brief reminder, there are 4 performance categories that make up MIPS. And based on your performance in these various categories, you get a combined score. And based on your combined score, you may or may not get an adjustment up or down. If you're exactly in performance threshold, there's no adjustment. If you're above it, you get a bonus. And if you're below it, you get a penalty. So let's talk about some general updates for year 2. So registry. It's almost as much fun to do a wedding registry as it is to do a data registry. So this is the data registry. It's clinical, it's the Qualified Clinical Data Registry, or QCDR. The QCDR is a way to electronically submit data. Now, there are a lot of advantages to using these QCDRs. One of them, they have more measures available to you. We used to call these non-MIPS measures. Now they're called QCDR measures. It's the same thing. It's additional measures that are available to you. Also, you can get more timely feedback on how you're doing. And in addition to having more measures and getting feedback, you can actually help select the measures you're going to submit on. All these are ways for you to optimize your score. So the QCDRs will help you optimize your score. Now, even beyond MACRA, just forgetting MACRA for a second, there's reasons to use the QCDRs, particularly the ACR one, the National Radiology Data Registry. They're very useful from a QI perspective. You can benchmark how you're doing, keep track of how you're doing. So even beyond the MACRA stuff, the QCDRs, like the NRDR, are very useful from a QI perspective. There are other QCDRs for radiology beyond the NRDR, but the NRDR is the one from the American College of Radiology. So let's talk about who has to do MIPS, because some people are excluded. As you saw before, I would be excluded as an individual. So there's a few ways to get excluded. One way, if you have meaningful participation in these advanced APMs, and Dr. Golding will describe what that means, then you're out of it. You don't have to worry about it. If you're below the low volume threshold, you don't have to do MIPS. I'll be describing what that means. And if it's your first year in Medicare, you don't have to do it. So those are the 3 big ways you can get out of MIPS. Now, last year there was a special thing. Because of the hurricanes and the fires, CMS issued this extreme and uncontrollable circumstances policy, but that was for 2017. There is nothing for 2018. So all of that stuff about fires and hurricanes that meant for 2017 you didn't have to do anything, that does not apply for 2018. So let's talk about the low volume threshold. I put a new tag here because this is actually different than it was last year. The government changed the threshold. They made it higher, making it easier to be exempt from MIPS. So if you bill $90,000 or less to Part B, or you have 200 or less Part B patients, then you don't have to do MIPS. Now, as a pediatric radiologist, I don't do $90,000 200 Part B patients, so that's why I was excluded. I'm excluded under the low volume threshold. However, as a practice, we do bill more than $90,000 and see more than 200 Part B patients. Therefore, as a practice, we are not excluded via the low volume threshold. It does not scale. So as an individual, I would be excluded. As a practice, I am not. But this is a change from last year, making it easier to be excluded. Now, let's briefly discuss patient-facing. It hasn't really changed, but it's an important issue, and it's a little bit confusing, so it's worth going through at least briefly. So patient-facing status is based on these patient-facing encounter codes, these CPT codes. If you bill 100 or less of these patient-facing encounter codes, you are considered non-patient-facing. There are some advantages to being non-patient-facing. There are actually some advantages to being patient-facing too, but at least there seems to be an easier burden if you're non-patient-facing. So if you bill 100 or less of these patient-facing encounter codes, you are non-patient-facing. That's at the individual level. At the practice level, if more than 75% of the providers in your practice are non-patient-facing, the practice is then considered non-patient-facing. So in this illustrative sample, what you'll see is because there's one person patient-facing and 4 are not, the practice would be considered non-patient-facing. 80% of the people in this practice are non-patient-facing. However, if one of them turns around and becomes patient-facing, now 40% of the practice is patient-facing. The practice is now considered patient-facing, even though a plurality, 60% of the people in the practice are non-patient-facing, the practice is still considered patient-facing. If you actually want to know about those different codes, you can look it up. Here's the website, the CMS.gov website. You can actually see the URL here. You would scroll down, and there's actually an Excel file that you can download and look through. One thing that I will point out, which was a nice win for radiologists, we got them to take out 8 different codes dealing with 5 different procedures that makes it easier for us to stay non-patient-facing. It took out things like thoracentesis, paracentesis, lumbar puncture, myelography, joint injections. All of these things were taken out of the patient-facing encounter code list, making it easier to stay non-patient-facing. Now let's get back to small and rural practices. Now, as I mentioned, the government really wants to limit the burden on these practices. So when they say small, what they mean is 15 or less eligible clinicians for MIPS. We've already talked about the low volume threshold, which they raised to make it easier. Dr. Golding is an expert and has a new paper on the virtual group option. She'll be discussing that. If you're in a small rural practice, you don't have to do the advancing care information. That's one of the 4 performance categories in MIPS. With the improvement activities, a different performance activity, you actually have a much lower burden. It's actually a lot easier to do. And you get extra points just for being in a small practice. There's also technical assistance available for you if you are in one of these smaller rural practices. Again, they're trying to make the burden a lot easier. So let's talk about the point system. So it's a 0 to 100 scale. With the performance threshold this year set at 15, what it means is that if you're below 15, you get a penalty. If you're at 15, there's no adjustment, and if you're above 15, you get a bonus. Now, for the next 3 years, the performance threshold can be set by CMS, and they presumably will keep it artificially low, meaning that it will be relatively easy to avoid a penalty. Now, because there's budget neutrality, meaning that the pool for bonuses is fed by the pool from the penalties, that means the bonus pool is probably going to be pretty small too. So for the next few years, it's probably going to be a transition too, meaning that the bonus and the penalty pools will probably be pretty small, with one caveat. If you get a 70 or above, that's so-called exceptional performance. There's actually extra money set aside for those that score 70 or above in that so-called exceptional performance category. So bonus points. You can actually get bonus points. So there's bonus points for things like if you've got a lot of complex patients, you can get up to 5 extra points in your final score. If you're a small practice, just for being a small practice and submitting something. If you're a small practice and you try to submit, boom, you get 5 points. You're a third of the way there just for existing and trying. And they're going to continue their bonus system from last year as well. Now, a word on the complex patients. Again, you can get up to 5 points. Dr. Andrew Rosenkrantz and colleagues have a new article this month in Academic Radiology highlighting complex patients in radiology. And what it says is that overall, in general, radiology tends to have higher complexity patients. Now, this may vary for lots of reasons in different locales, but overall, in general, radiology should do well with this complexity because overall radiology tends to have more complex patients. Now, improvement scoring, this is kind of a weird, complex topic. Basically, what it means is that for this current year, 2018, if you do better in quality and cost than you did last year, they can improve your scores based on the fact that, well, you know what, you did better. We're going to give you a little bit of extra points for doing better. Now, what they've already said is that the cost one, we're not going to do that one again. So for this year, you actually can have improvement bonus points for quality and cost. But for next year, they've already said we're going to drop costs. We're only going to do quality for next year. We're not going to do cost again. So it's a little bit unusual, but at least it's a way you can get some extra points if you do better. Now, the payment adjustment. Now, there's the traditional 2-year lag, meaning this 2018 performance year equates to the 2020 payment year. The penalty for this year will be 5% to be dealt in 2020. The bonus will be 5% times the scaling factor. Remember, that scaling factor is there to preserve budget neutrality, meaning that the penalty pool pays the bonus pool. The losers pay the winners. Don't be in the loser pool. But because they expect that penalty pool to be so small, the bonus pool is probably going to be pretty small too. And remember, there's an extra $500 million there for people that score 70 or above, those so-called exceptional performers. So here's how it might break down. Now, this is simply illustrated because we don't actually know what the adjustment factor is going to be. If I had to guess, it's probably not going to be this far off what this looks like. The reason I say that is that if you see at 15, okay, we know that's going to be zero adjustment. That's the rule. We know that 70 or above, there's some extra money. And we know that 15 or below, you're going to get a penalty. But what happens between a little bit over 15 and 70? Bonus probably isn't going to be that much because the penalty pool is so small. But nobody knows exactly what it's going to be yet until, of course, things happen. CMS has sort of put on a guess what they think, but nobody actually knows. And I've put the final rule page number here if anybody wanted to read more about it. There's additional details here along with the final rule page number if somebody wanted to read more about it. It shows you if your final score is this, kind of how are they going to adjust your payment. But again, we won't know exactly what it is until the data starts trickling in. Now, going beyond the financial adjustments that are going to happen, there's reasons to be paying attention to this, and one of them is the physician compare. In the rule, what it says is that they are going to post ratings publicly on this physician compare website. Now, you could argue that this is not a very good measure of the quality of you or your practice, and I would probably agree with a lot of these people. However, I would also argue that patients may not necessarily understand that nuance. And so because they may look at it, it's sort of like combing your hair for the class picture. You don't have to do it, but it's probably a good idea since people are going to see it. So because they literally have things written on here like more stars are better, patients are going to look at that. I don't know, it says more stars are better. They're going to think that more stars really mean better, and they might not appreciate any nuance that has to do with it. So let's talk about the different performance categories. So as we mentioned before, there are 4 performance categories. Here are the different weightings for those different categories. One thing that I want you to notice is that regardless of whether you are patient-facing or non-patient-facing, cost is 10%. It doesn't change. Dr. Golding will be going over this in detail. One thing that has changed is the performance periods. Last year, you only had to do at a minimum 90 continuous days of quality. This year, it is a full calendar year for both quality and cost, a full year. For ACI and improvement activities, it's still 90 continuous days. Now let's talk about the 4 individual performance categories, starting with the first one, quality. So quality, whether you're patient-facing or non-patient-facing, is a huge part of your score. If you're non-patient-facing, it's 3/4 of your score, so it's worth paying attention to. So here's how you do the quality scoring. You submit data on 6 measures, and you get a score between 1 to 10, so you can get up to 60 points. 6 times 10, 60. So here's a little bit of nuance about it. If a benchmark exists, meaning there's actually data out there and they can put you into deciles, then the floor becomes 3 points, meaning if you really just do a bad job on it, they're not going to give you 1 point. They'll give you 3 points, even if you don't do a good job. However, if there's no benchmark or you don't submit enough cases, like 20 cases, they're just going to give you 3 points. They're just going to flat out give you 3 points. And if you don't submit a high enough percentage of cases, and we'll talk about what that means, they're just going to give you 1 point. So if you only submit 10% of your cases, they're only going to give you 1 point. Unless you're in a small group, then they'll actually give you 3 points. Again, advantages to being in a small group. So regarding that data completeness, what they've said is that for this year, 60% is the magic number. So if you were submitting via a registry, you have to submit data on 60% of your patients that would meet that measure, of all patients that meet that measure. If you're using claims, it's 60% of your Part B Medicare patients that would be applicable to. So if you only submit data on half of them that's applicable, that won't be enough. You're only going to get 1 point, unless you're in a small practice. In that case, they'll give you 3. Top-down measures, this is also a change from last year. They introduced a new schedule to sort of roll out these or get rid of these top-down measures. Top-down means a measure that everybody already does really well on, so they feel like it's not as valuable, so they sort of want to get rid of it. And what they said is that they're going to create this new schedule to sort of get rid of top-down measures, and they're going to cap the number of points at 7 after 2 years. They've already gone ahead and identified 6 measures for this year, which they're calling topped out. I've listed them for you here. The ones on the right-hand side of the screen, measures 262 and 359, these are already topped out, and these involve radiology somehow. So for this performance year, these measures are already identified as topped out, meaning that they're only worth 7 points, they're not worth 10 points. Let's talk about a new category, the new one, improvement activities. So we did quality first, and now let's talk about improvement activities. Now this is really the same as last year. Improvement activities really hasn't changed since last year. It's pretty much the same. So if you're a regular patient-facing group, you've got to submit 2 high-weighted, 4 medium-weighted, or 1 high and 2 medium-weighted to get full credit. If, however, you are a small practice, a rural practice, or you are non-patient-facing, it's half that burden. This is the same as last year. You only have to do 1 high-weighted or 2 medium-weighted activities. And you only need 1 person in the group to do it and get credit for the entire group. So 1 person has to do it. It's got to be 90 continuous days, and the entire group will get credit. And you can simply do it via attestation. You can also use those QCDRs, but literally you can just do an attestation saying, you know what, 1 person in the practice did it for 90 continuous days, and you will get credit for improvement activities for the entire practice. So here is my big pearl for you. Improvement activities is 15% of your score. Because it is 15% of your score, if you get a 100% score on this, you will get 15 points. The performance threshold is 15 points. So let's say you're a non-patient-facing practice. All you would need to do to avoid the penalty is attest doing 1 highly weighted activity. If you do that, if you forget about everything else, but you attest to doing one person in your practice attests to doing 1 highly weighted activity for 90 continuous days, you will get a score of 15. That is the performance threshold. You will not get a penalty. You won't get a bonus, but you certainly won't get a penalty. Now, there are reasons not to do this because you want to do well in the quality section and other things as well, but if all you want to do is avoid a penalty, this is a pathway to avoiding a penalty. So what are some measures you could use? So I've listed them here if you want everyone to look at it or screenshot it. I've listed the various measures as well as what they are, as well as their weighting, as well as a relevant page number. You'll see there is actually a question mark by TCPI because the language in the final rule actually contradicts itself a little bit, and so we've gone through it. But at the very least, you would get medium weighting, possibly even high. But these are some possible measures that you could use. Now, I did want to give a shout out to RScan. If you are using RScan, and I put the URL here, you can get IA credit very easily. So go to the rscan.org website, and you would click on Why RScan, and then Earn Improvement Activity Credits. And it lists numerous IA measures that are applicable to you because you are doing RScan. So if you're doing RScan, there are enough improvement activity measures that apply to you that you will get full credit whether you are patient-facing or non-patient-facing. So this is another reason to be involved and active with the RScan program. And then my final slide, this is a great way to help your clinicians. This doesn't necessarily help us directly. This is for clinicians. If your institution is using appropriate use criteria and clinical decision support, then the clinicians can claim this measure, IA PSPA 29. It's not for radiologists, it's for clinicians, but it's a nice way that we're helping them. And you should make sure they know, your clinicians, that, hey, if you guys are using MIPS and looking for a new improvement activity measure, if you're using clinical support, this can help you. And so they may appreciate that benefit. So with that, I will wrap up my section, and I'm going to toss it back to Dr. Nicola.
Thanks, Rich. I appreciate that. And again, for everyone who's signed on, these slides will be made available on the ACR website and the YouTube channel. And I want to thank Rich for highlighting the changes for year 2 in the QPP. And now I'm going to turn it over to our colleague, Lauren Golding, and Lauren's going to finish up talking about MIPS and APMs. Thanks, Lauren. Lauren, we can't hear you. You might have to unmute yourself.
Okay, can you hear me now?
Yes, thank you.
Okay. Thanks, everybody. Thank you for joining us tonight. So despite what MedPAC might want you to believe, this picture is not in reference to MIPS, but just a reassurance for our audience that you're about halfway through the webinar. I'm going to pick right up where Rich left off and finish talking about the performance categories with advancing care information and cost. And I'm going to spend some time on cost because this is one of the major changes for 2018, and I think it's one of the least well understood of the performance categories. Then we're going to discuss some new reporting options that are available in 2018 and briefly one that's coming in 2019, and wrap up with some updates on alternative payment models. So Rich discussed quality and improvement activities. The next performance category is advancing care information. This is the MIPS version of meaningful use that most of us are familiar with. Just as a review, your ACI score is made up of a base score, a performance score, and a bonus score, and these are added together to get your total ACI performance category score. CMS has set forth 6 objectives with corresponding measures that are required to report into the base score. And this year they're allowing exclusions for e-prescribing or health information exchange. So if you're unable to report into those, they'll still let you report into ACI. What's new for ACI in 2018? Well, you can still use 2014 or 2015 edition Certified Electronic Health Record Technology, but you'll get a 10% bonus if you're using exclusively 2015 edition. There's 2 other adjustments to the bonus structure that may be relevant to radiologists. You can get 10 percentage points in the performance category if you report into a clinical data registry. Last year this had to be in an immunization registry, but CMS acknowledges that some clinicians don't have an immunization registry available to them, so you can get these points for using any clinical data registry. And then you can get 5 percentage points in the bonus category if you use a second clinical data registry. Also, you can get a 10% bonus if you use Certified Electronic Health Record Technology to report an improvement activity. And this crossover in a MIPS performance categories is something that we think we may see more of in the future. So most of you can forget everything that I just said because most radiologists will be exempt from the advancing care information category. This is a list of the exemptions here. Many of us will be defined as non-patient facing clinicians, but if you do a lot of procedures or your practice is heavily weighted towards interventionalists, you do have some other options. I'll note that the hospital-based definition was expanded this year to include point-of-service 19 or hospital outpatient departments. This was a big deal for my practice because we were right on the cusp of being patient-facing, but with POS 19 added to the hospital definition, we were easily exempt. There's a new hardship exemption for small practices and one for participants whose EHR has been decertified. So I think we all breathe a collective sigh of relief that most radiologists are exempt from ACI, because historically the mandated activities weren't really that relevant to us. But you can make an argument that by not participating in ACI, that radiologists could be disadvantaged in MIPS and in APMs. So there's bonus points available in quality if you use end-to-end electronic reporting to report your measures. Also, as I just mentioned, there's bonus points available if you use Certified Electronic Health Record Technology to report your improvement activities. So if radiologists have an integrated cert, they might miss out on these scoring opportunities. As for APMs, by definition, an advanced APM requires its participants to use Certified Electronic Health Record Technology, or at least 50% of them. So if a radiologist hasn't adopted it, then they may threaten their APM entity's ability to meet that threshold, or they may not be invited to participate in the first place. So we saved the best for last, and I'm going to move on to talk about the cost category. Cost will come into play in 2018 and will comprise 10% of your final score in MIPS. The performance period is the calendar year, and you don't have to do anything for this measure. There's no submission requirements. CMS will automatically calculate your score based on administrative claims. The benchmark is based on the performance period, so you don't really know what you're being compared against until it's all said and done. A common misconception is that non-patient facing clinicians are exempt from cost, and that's not the case. A radiologist will still be scored under cost if they meet the attribution threshold, regardless of their patient-facing status. There is some verbiage in the rule that states that CMS anticipates non-patient facing clinicians won't be attributed any cost measures, but we are seeing that happen, and I'll describe more about that, explain a little bit more about that when we talk about the specific measures. So CMS initially proposed keeping costs at 0% for 2018. I think we were all a little surprised when the final rule set it at 10%, and that impending sense of doom was really heightened because the MACRA statute mandates that cost increase to 30% by 2019. Well, Congress has an uncanny knack of releasing major policy changes between the time we make our slides and actually give presentations like this, and that's exactly what they did with the Bipartisan Budget Act that was passed on February 9th. Among other provisions, this act allowed CMS to keep costs at 10% through 2021 for the next 3 years. So maybe the sky isn't falling after all, or at least not as quickly. Let's dive a little bit deeper into the specific measures in the cost category. There's 3 of them. 2 of them are carryovers from the value-based modifier program. One of them you shouldn't have to worry about, and that's total per capita cost. It's essentially a primary care measure. The other you don't have to worry about yet, and those are the episode-based cost measures. But these are important and they're coming, so we will talk about them in a minute. For most radiologists, the only measure that will apply is Medicare spending per beneficiary, or MSPB. MSPB measures the cost associated with an inpatient hospital admission from 3 days before admission to 30 days after discharge. You might argue that a radiologist doesn't have a lot of control over the total spending during admission, but this is a broad system-wide measure that applies to all clinicians in all hospitals, and it makes sense why CMS would want to use this measure as a way to encourage team-based accountability for cost of care. So how does this work? A patient will be attributed to you if you bill the plurality of services, Medicare services, for that patient during an episode. MSPB will apply to an individual or clinician who meets the attribution threshold of 35 beneficiaries. And I want to point out that that 35 threshold applies at the individual, group, and the virtual group level. So MSPB was part of value modifier, except the threshold used to be 125 beneficiaries. But there's an interesting twist here, interesting, of course, being a relative term, in that under value-based modifier, MSPB was attributed at the 10 level. So if your group was responsible for the plurality of services for a patient, that patient would be attributed to you. In MIPS, MSPB is applied at the MPI level. So an individual radiologist would have to bill the plurality of services in order for that patient to be attributed. You can imagine in a multi-specialty practice, different radiologists may read the chest, abdomen, pelvis CT than the one who reads the head, neck, and face, or different radiologists might do interventional procedures on a patient than the one who reads diagnostic imaging studies, and a patient that would have been attributed to your 10 under value-based modifier. It's not really clear what the net effect of the lower threshold, but the favorable attribution methodology will have on how many radiologists will end up being accountable for costs. So back to the not yet measure. CMS had preliminarily adopted 10 episode-based cost measures for 2017, but they decided not to use those in 2018, instead focusing their efforts on developing new measures with more significant clinician input. And the ACR is heavily involved in this process with representation on the clinical subcommittees working on measure development. There's 8 measures that have been pilot tested, and these will likely be implemented in 2019. While these measures don't apply directly to radiologists, there are a lot of measures in the pipeline that will. As part of this process, CMS designed patient relationship codes that are designed to help attribute costs to individual physicians within the episodes. These are modifiers that can be voluntarily appended to claims starting in 2018, but we haven't gotten a lot of guidance from CMS on how exactly to use these modifiers since they happen to be out before the episode measures are. So for now, we're recommending holding off on reporting any of these patient relationship codes until we have more information. So I'm telling you that your score in the cost category is going to be entirely based on this single system-wide measure over which you likely have little control, and I can't even tell you whether you'll be held accountable or not, and even if I could, I can't tell you how you might perform because the benchmark is based on the performance period. So maybe the sky is falling, but there are some ways you can optimize your success in the cost category, and the first is to be informed. The easiest way to do that is to look at your group's QRU, or Quality Resource Use Report from CMS. And this was a feedback report used in value-based modifier, and there's a ton of information here. It gives you information about how many beneficiaries were attributed to you, and it lists the individual patients. You can see their risk score, you can see their primary diagnosis, and the total cost. So this is a good way to be informed about whether or not you might be accountable for costs and how you might perform. Remember that cost isn't necessarily a bad thing. Maybe you're doing great, and it might actually help your MIPS score. Even though a single radiologist may not have a lot of impact on total cost of care, your practice as a whole certainly can do some things that will lower cost. And this probably includes working with your hospital or your health system on projects like clinical decision support or the RScan quality improvement project. In general, a radiologist will perform well on cost if the system in which they practice performs well on cost. So we're going to shift gears and talk about some new participation options for 2018 and one in 2019. In 2017, there were 2 ways to participate in MIPS, as an individual or as a group. The MACRA statute mandated a 3rd participation option, the virtual group, and that's available now in 2018. There's another reporting option that was described in the proposed rule for 2018, but CMS decided to delay the implementation until 2019, and that's a facility-based measurement option. This option gives facility-based clinicians the ability to be assessed on measures from the hospital value-based purchasing program. As it stands right now, there are not a ton of radiologists who would be eligible to participate in facility-based measurement, but the statute does specifically allow the use of hospital outpatient measures for radiology, and that includes imaging efficiency measures like the double CT scan rate, so this may be more relevant to radiologists in the future. So facility-based measurement was delayed till 2019, but the virtual group option is available now in 2018. A virtual group can be made up of solo practitioners and groups of 10 or fewer eligible clinicians who come together virtually to participate in MIPS for a performance period for a year. There's no restrictions currently on the geography or specialty or number of groups that can come together to form a virtual group. And the members in a virtual group are scored as a group across all 4 MIPS performance categories. So they get a uniform score and a uniform payment adjustment. CMS has made available a virtual group toolkit on the resource library webpage, and that has more details about the requirements in the election process. You have to elect to participate in a virtual group by December prior to the performance year, and once you've elected, you can't get out of it for the entirety of that performance year. There's some obvious advantages for small practices with limited infrastructure to combine resources across multiple groups in a virtual group. But you have to remember that there are some trade-offs associated with foregoing some of the small practice provisions. So remember, a small practice is defined as 15 or fewer eligible clinicians. So if a small practice that would have been eligible for the bonus joins a virtual group and no longer meets the small practice definition, they will be giving up those bonus points. Also, you remember I mentioned that MSPB was the attribution threshold of 35 applies at the individual group and virtual group level. So a group that might not have been accountable for cost at the group level may be accountable if the virtual group beneficiaries exceed 35. Another unique advantage for small practices are the groups that might report to MIPS using might report to Medicare using multiple TENs. So these kind of groups can form a virtual group with themselves in order to consolidate their TENs and for ease of reporting. I refer you to this article that we recently published in JACR for more details of the virtual group option and strategic considerations for radiologists. So the bulk of this webinar has been focused on MIPS because that's where most radiologists will find themselves. But I'm going to wrap up by talking about advanced alternative payment models, which is the other arm of MACRA. So if you only remember one slide from this presentation, I would recommend this one. This is a figure from a white paper on alternative payment models put out by the Learning Action Network, which is a collaborative between public and private stakeholders who are tasked with accelerating the transition to value-based care. The white paper is great, and I recommend you read it in your free time. But for now, I want you to focus your attention on this big orange dot. So this represents the volume of healthcare services that are provided under fee-for-service in the world we live in now. Now look what happens to the orange dot in the future state. It's microscopic. So future state here isn't talking 10 to 20 years from now. And I think this is a powerful visual reminder that no matter what happens to MIPS, there's going to be a continued push away from fee-for-service and into some kind of risk-based payment model. I just want to review quickly the requirements for an advanced alternative payment model and the incentives for being in one. So under the QPP, a participant who sufficiently participates in an advanced alternative payment model is eligible for a 5% lump sum bonus on all their Medicare Part B payments, and they're exempt from MIPS. But all APMs aren't created equal, and you have to be in the right one. To qualify as an advanced APM, you have to meet 3 criteria. First, your payments have to be based on quality measures that are comparable to those in MIPS. You have to bear more than nominal financial risk, and your participants have to use CERT. Even if you are in the right kind of APM or an advanced APM, you may not be eligible for a bonus if you don't have enough patients or enough dollars coming through the APM. This chart shows the thresholds that are required to be a qualified participant in an APM or a QP. If you don't meet these thresholds, you may be considered a partial QP, You're still exempt from MIPS, but you don't get the bonus. You can see that these thresholds progressively increase rather rapidly over the next few years. There's not a lot of changes on the APM side of things. For 2018, CMS did extend the 8% revenue-based nominal risk standard for another 2 years, and they introduced the all-payer combination option. This is an option where clinicians can achieve QP status by combining participation in a Medicare advanced APM with an other payer advanced APM, and that will be available in 2019. There's a couple of new advanced alternative payment models on the scene, and one I want to highlight briefly is the Bundled Payment for Care Initiative Advanced. CMS announced this in January, and this is a new voluntary bundled payment program. Under BPCI Advanced, organizations can receive bundled payments for up to 32 clinical episodes, for which they're held accountable for quality and cost. BPCI Advanced is built on its predecessor, BPCI, with a couple of important changes. First, this one qualifies as an advanced APM under MACRA. Second, it's the first program to include outpatient episodes. And third, BPCI Advanced accounts for patient case mix by risk adjusting the target price. There was a lot of criticism about BPCI and some of the earlier programs like comprehensive care for joint replacement because they were susceptible to cherry picking some of the lower risk patients. This is a busy slide, but it lists the clinical episodes that are available in BPCI Advanced. There's 29 inpatient and 3 outpatient clinical episodes. And you can see that several of these would be relevant to radiology. So we've covered a ton of information tonight. I want to highlight a couple of the major changes for 2018. There are more exemptions this time around, both in the program as a whole and specific to the ACI category. Cost will come into play. It'll count for 10% of your final score in 2018, and small practices have the option to participate as a virtual group. And 2 more takeaways from the Bipartisan Budget Act that I want to highlight is that CMS now has the flexibility to keep costs at 10% through 2021 and gradually increase the performance threshold through 2021. The implications of this are that it's going to be a lot easier to avoid a negative payment adjustment in the next few years of MIPS, but the flip side of that is that there's going to be a much more limited pool of money available for high performers. And some of the more advanced practices may start to consider moving into APMs. So you have reached the end of the webinar, but probably not the end of MIPS and definitely not the end of value-based care. The concepts of paying for performance, measuring outcomes, and proving our value are here to stay, and they're worth investment for your practice. Thank you, and I'll turn it back over to Greg for our Q&A session.
Great, thank you, Lauren and Rich. That was an excellent summary of all the updates for QPP Year 2, which again is the 2018 performance year, which we're already several months into, or at least 2 months. We're now open for questions, which can be put through the chat function, and I'll have to also defer to our wonderful staff on whether we can take actual live comments through the phone. I'm not sure we can. We may be able to. As part of the finishing up, I want to thank everybody on the MACRA committee who has helped us put together this webinar and all the knowledge that we've learned through the QPP, but most importantly, the ACR staff. They're terrific and constantly meeting with CMS and meeting with the volunteers at the ACR and making sure we're all up to date on what's going on the regulatory and statutory side, and they're just a terrific staff that we're all honored to work with. At this point, we'll go ahead and open up the questions, and if there aren't any questions, I have a couple questions for the presenters.
Hey, Dr. Nicola. Looks like we don't have any questions yet, but just want to remind everybody they can either click the hand raise button or they can enter the questions into the question box, and we will ask those and answer them.
Great. So I'll ask a question, and either Rich or Lauren can answer this. Lauren, it's best directed towards you because you made reference to it. MedPAC recently came out with recommendations in October and then further strengthened them recently about abolishing MIPS. What's your take on that? Do you think that's going to have some traction, or do we see Congress getting rid of MIPS anytime soon, or what's your opinion?
Well, I think that's a great question. We've seen recommendations from MedPAC before along similar lines, and not much has really happened from it. I will say that in the President's budget for 2019, there was some mention of easing requirements in MIPS and some specific provisions that might make some important changes. But until we actually see that legislatively, I don't really know that we can hang our hat on any of that. And I think kind of the take-home message is that MIPS and the specifics of MIPS may change, but the concepts of value-based care are going to stick around. I mean, clearly there's commitment from this administration and pretty much anyone that comes to transitioning away from fee-for-service. So, if you're questioning whether your practice should dump a ton of money into things specific to MIPS, I wouldn't necessarily recommend that. But if you're looking at focusing on quality and measurement and those types of concepts in general, I think that that's money that would be well spent.
Thank you.
And we do have a couple questions that have just come in. We've got the first one here from Andrew Zyberg. He's asking, is the cost category applicable to outpatient, non-hospital-based imaging centers?
Lauren, do you want to take that?
Sure. So the cost measures that we currently have are the total per capita cost, that's pretty much a primary care measure, and then MSPB, and that's exclusively an inpatient measure. Those episode-based measures that I talked about earlier, they're still in development. It's possible that they'll have some outpatient components, but if you're exclusively outpatient with no inpatient services at all, then MSPB is unlikely to be attributed to you. Even if a couple of patients are for some reason, you have to hit that 35 threshold for attributed beneficiaries.
Yeah, so the short answer is there's no. The outpatient radiology practices will not have any cost measures applied to them. For 2018, for sure, they won't have any.
Thanks. Our next question comes from Mike Higgins. Mike asks, for practices participating in MIPS, does it mean we can completely ignore and forget about the meaningful use requirements and attesting to meaningful use?
Rich, Lauren, you guys go ahead and take all these if you like.
Well, a lot of meaningful use has its corollary in MIPS in the advancing care information category. So some of those measures and concepts are carryovers from that. So specifically, do you have to address the meaningful use program? No, but you do have to participate in advancing care information unless you're exempt for one of those exemption categories that I listed. If you're non-patient facing, then no, you don't have to worry about meaningful use anymore. If you do happen to be patient-facing and you don't meet any of those other exclusion criteria, then you will have to participate by reporting the base measures and the performance measures in ACI.
And I just want to reiterate that Rich showed a really important slide in the beginning where you can type in your NPI number and and find out if you are non-patient facing. We've done claims-based research on this concept and found that probably over 90% of diagnostic radiologists will be non-patient facing, and therefore they will not have to do advancing care information, which is the new permutation of meaningful use, and wouldn't have to worry about that. So I strongly suggest taking Rich's advice and typing in your NPI and finding out if you are going to be responsible for advancing care information or not. And that website, qpp.cms.gov, will tell you that.
Thank you. The next question's for all three of you, so whoever wants to answer. This is from Becky Haynes, and she's asking, how do you work within your practices to get others on board with these changes?
Rich, do you want to take a stab? I'll go ahead and answer that. This is Greg. In all honesty, this just doesn't work without a physician champion. So usually there's one point person who's going to really take on the burden of this. And in my experience, the best way to at least get engagement is to provide your coworkers with feedback. And one of the reasons I personally like to use the Qualified Clinical Data Registry option, the National Radiology Data Registry, is that it makes the entire process more interactive. What we saw in the physician quality reporting system, near the end of the physician quality reporting system, you could use registries, but through much of it you couldn't, and there wasn't a lot of feedback, and physicians didn't know what was going on, and it really became a back office activity. I think with the new data tools available, including registries, that you can start engaging your clinicians on what they're doing and providing quarterly feedback. I think that's a great way to at least start educating your practice. But in all honesty, if you don't have at least one point person that's really going to go in and dive deep, this really becomes a very cumbersome and difficult process. And I think it's a setup for failure. But the real idea here is to take this as a stepping stone to understanding where the whole health economy is going. And if you at least have one physician champion who's providing feedback to his or her group, it's the beginning of using data to influence care. And I think that's the first step we all need to take.
Thank you. The next question here is from Barbara Mulick. Barbara's asking, if a private radiologist practice utilizes a CERT owned by the hospital but cannot participate as ACI provider in that CERT, can they still participate in an advanced APM with the hospital, i.e. they will not be counted in the MIU reporting of the CERT?
Yes, I think I understand the structure she's talking about. I mean, they're using hospital cert. It's okay that they don't own it. It's just as long as they're on it and have access to it, and they can participate in an advanced APM. There's a lot of nuances to this question that I'd have to ask a couple more questions. But in general, if you're using hospital cert as part of your imaging practice, you're okay.
Thank you. The next question is from Kelly Whittle. Kelly's asking, thank you for working to remove the 8 codes from the non-patient facing list. It is helpful. Do you have recommendations for streamlining the documentation process when capturing quality measure criteria?
Well, I can just talk from personal experience, and Lauren can certainly talk about this, and so can Rich. I started using QCR when it first became recognized as a mechanism to report into CMS quality programs in 2014. So after about 3 or 4 years, I've learned all different tricks to streamline quality measure capture. Currently, I have about 4 or 5 mechanisms of capturing those quality measures. Anything from certified electronic health records helping me capture them, to voice recognition software at least structuring the reports and at least making it easier to capture, to having a billing company help me capture measures, and our own individual physicians helping capture measures. So I have a 4-pronged approach that I think has little impact on day-to-day clinical care, and we've streamlined enough. But it took me a number of years to get that approach implemented. But now I'm able to capture roughly over 30 measures, and it's much more streamlined. But I will say that it took me a number of years to really get it to the point where it's fairly automated. And I definitely understand the pain. The key is baby steps. The other key is that, again, we can't flat out recommend a large infrastructure spend on something like this because of how labile sometimes regulatory language and statutory language can be, especially in healthcare and different political administrations and wishes. But at the same time, I do think the process of learning to capture quality data and cost data and learning to work with it are lessons learned and worth learning in any kind of environment as we transition to value-based care, which is certainly going to be a definitive. We will be transitioning how we do it, whether it's MIPS or some other paradigm, I don't know. But I do think at least going through the exercises of learning how to capture measures and react and improve care is an important lesson. And however you streamline it, it can take a long time. And it probably won't be one universal way.
Greg, can you guys hear me now? It's Rich Hauer.
Yeah.
So I would add, I think I was muted before, so I'll give you my 2 cents on this, which first of all, I agree with everything Greg said. And then I would add that the billing company really can be engaged here and can really help you. But a lot of it is this is really a great role for technology to really do a heavy lift, and they can be part of, at least in our practice experience, it can be part of various QI projects that we're doing. So we can try to link a QI project that we're doing and then use the technology to sort of classify everything. And so even if that MIPS category changes, fine, we're still doing a QI project and we're doing it for the right reason. And it's a nice benefit if the MIPS category lines up. But even if that MIPS category goes away, yeah, we're still doing the right thing for the patient. In the end, we're doing the right thing, and we're using technology to really help us with the lift in terms of going through all the data. And it's a great use of technology.
Yeah, and that is the key, is that, we have technology nowadays and we should be using it to provide us feedback. And that really is the essence of MIPS. Granted, some of the measures I don't agree with, but the concept of measuring and feedback is key, and you have to leverage technology every way that you can.
Thank you. Right now we've just got one question left, and this is from Ann Horan. Ann is asking, if we do not do ACI due to low patient-facing codes, do we need to find more quality measures?
No.
No, so those are
No, you don't.
categories. For the quality performance category, you only have to report 6 measures. You can report additional ones if you want extra bonus points, but for now at least, those categories are separate, and ACI exemption doesn't affect your quality reporting measures at all.
So if you're non-patient facing, the weighting just gets shifted over to the weighting gets shifted over, so that quality section just has more weight. You still have the 6 performance categories as your base. It just has a higher weight of your total final score.
Yeah, that's correct. And there's just a maximum number of points you get in quality, and so if you can do that with 6 measures, that's great. And that's all you need is 6 measures to get those maximum points if you've done well on all of them.
Great. Looks like that's all the questions we have for now. So I'll let you know if we get another one, but we could wrap up if you're ready.
Yeah, I think we're at the top of the hour, and we have a good recorded session here again that will be available on the website shortly after this is finished tonight. And we want to thank, again, the organizers and the ACR staff for helping us put this on, and hopefully this will be of great value to our membership for moving forward. Thank you very much, Zach, Lauren, and Rich.
Thank you for including me. It was a pleasure.
Good night, everybody.